Welcome to PGOG, Pathways to Growth in Obstetrics and Gynecology for postgraduates and consultants. Today's topic is ovarian cancer, the important concepts. Now, this is quite a lengthy topic, ovarian malignancy or ovarian tumors or ovarian enlargements, and that is why I have selected only the specific points where it will help for the clearing of the concepts related to the topic. Now, all these, again, to repeat whatever I have said at the introduction of this YouTube channel, PGOG, that these lectures, please remember that they are not replacing your own reading of the topic from the standard textbooks of your choice. And these are helping us. Whenever you want to prepare a topic, you can go through the video and then read it so that you will understand the important concepts, you will understand the important terminologies. But please remember that it is a supplement, it is not an alternative for your textbook reading. Now, the first, we will see what are the commonest pelvic masses as per the reproductive age of a in a female. For that, we divide the life of a woman in we can divide it in 5 parts. First is infancy and prepubertal age, then is the adolescent age, reproductive age group, that is from menarche to menopause, then perimenopausal group and postmenopausal group. Like that, we can divide it into 5. And it is important slide as far as differential diagnosis of ovarian tumors goes. You can even use it as a, if you are asked this question, what is the differential diagnosis of ovarian tumors? You can use this and you can divide it as per this age group also, so that it you don't miss out, and that really helps to for the better understanding in clinical situations also. So let us first focus on this infancy and prepubertal uh, age, where number one is functional cyst of the ovary. Now, functional cyst, as we are all aware, functional cyst common is the follicular cyst, followed by there can be corpus luteal cyst, and least common functional cyst example is theca lutein cyst. All these functional cysts are at the top of the list as cause of pelvic masses even in infancy and in prepubertal age group, followed by germ cell tumors. Now, in germ cell tumors, I have specifically marked it as a star. The reason is whenever there is an ovarian mass in infancy or prepubertal age group, the possibility of having a malignant germ cell tumor is very high. That we need to remember. So these are the two possibilities in young girls before puberty. Now, after puberty, in the adolescent age, again, number one is functional cyst, followed by sometimes there can be a pelvic mass, and surprise can be a pregnancy. Ovarian mass also with germ cell tumors can be there in this group also, but possibility of having mature teratomas is more as compared to malignant germ cell tumors as compared to prepubertal, where we know that malignancies are more younger the age of the girl is. But in adolescent age, we can have mature teratomas more commonly as compared to malignant germ cell tumors. Another reason for the pelvic masses we should remember in adolescent girls is there can be obstructing congenital malformations leading to vaginal mass or uterine mass, and that is a cause of pelvic mass in this age group. And last is here in adolescent age itself, epithelial ovarian tumors start appearing. So we can have a epithelial tumor in this age group also. Now shifting our focus to the reproductive, perimenopausal, and postmenopausal. Again, surprisingly, in reproductive age group also, we have functional cysts at the top of the list. Now, remember that we are diagnosing more and more functional cysts in all across all the age groups because of the greater use of ultrasonography. Even in adolescent age group also, any girl having persistent dysmenorrhea or heavy menstrual bleeding, ultrasonography is done, and what we get is a ultrasonography report showing a clear unilocular cyst without any solid areas, and then we should remember that the possibility of functional cyst is higher in such a scenario. Now, why we have to remember that functional cyst is number one for infancy, prepubertal, adolescent, and reproductive age group is it is the tumor cyst which is not neoplastic. It is non-neoplastic. It comes under the umbrella of non-neoplastic ovarian enlargement. There is never a possibility of it going for malignancy. These are majority of the time these are self-resolving unless it ruptures or there is a torsion. It remains asymptomatic, and usually with the OC pill used for 2 to 3 months to suppress HPO axis, there is spontaneous resolution of this functional cyst, and surgical intervention should be avoided in this because whenever we do surgery for ovarian mass, we should remember that post-operative adhesion formation is very high, reducing the fertility potential of young girls and women. And that is the reason we have to remember that functional cyst is always a possibility in a clear cyst without any locularity or without any solid areas. Followed by pregnancy, fibroids do start in the reproductive age group as a cause of pelvic mass, and epithelial ovarian tumors also do appear here. Perimenopausally, fibroid is at the top of the list, followed by epithelial tumors, but functional cyst is again a third possibility here also. Postmenopausally, in the elderly women, as expected, ovarian tumors are most common, malignant or benign, followed by again functional cyst. There can be bowel malignancies leading to pelvic masses, or metastasis in the pelvis is another reason of pelvic masses in the elderly postmenopausal women. So in nutshell, take home message is functional cysts are common across all the stages of a woman in the right from infancy to postmenopausal, and we need to be aware, and that is why I have included this slide. If you are asked this question now, ovarian tumors or ovarian mass or ovarian cancer, that is a common long case kept for your practical examination, or it is asked very commonly as a theory question also. So what are the causes of ovarian enlargement? If you are asked this question, you should divide it into causes of ovarian enlargement as non-neoplastic and neoplastic. Please do not confuse the functional cyst as neoplastic. That is the concept I want all of you to carry with you, that functional cysts come under non-neoplastic, which includes follicular cyst, corpus luteal cyst, or theca lutein cyst. Endometrioma, that is ovarian endometriosis, also comes under this non-neoplastic ovarian enlargement. Rarely we can have ovarian edema leading to the ovarian enlargement. So that is seen sometimes in young girls also. And luteum of pregnancy, I have seen 2-3 cases where there is virilization during pregnancy, and it is also spontaneously resolving after the pregnancy. There is no need to do any surgical interference. Correct diagnosis is more important, and that also comes under non-neoplastic ovarian enlargement. In neoplastic, we can divide it in benign and malignant. In benign, now for these two, there are 4 main groups we remember: epithelial ovarian tumors, germ cell tumors, sex cord stromal tumors, and metastatic. In epithelial, most common is serous, followed by all these others such as endometrioid, clear cell, mucinous, and Brenner tumors. All these, remember, they have 3 variants, not 2. Benign and malignant, not 2. But all epithelial tumors go through benign, borderline, or malignant. These are the 3 possibilities, where borderline is a variant in between benign and malignant or invasive tumor for all. Even for this mucinous, endometrioid, Brenner, or clear cell, also borderline variant is very much there. In the germ cell tumors, we have mature teratoma as the benign. In malignant germ cell tumors, most common is dysgerminoma, followed by immature teratoma and endodermal sinus tumor. Sex cord stromal tumors are hormone-producing tumors, where we can have thecoma, fibroma, androblastoma commonly as benign, and granulosa cell tumor, especially adult granulosa cell tumor, which is more commonly low-grade malignant tumor. And we can have metastatic tumors where primary is somewhere else and there is a spread of the malignancy to the ovary. Then it will be metastatic. If you are asked what are these borderline ovarian tumors? What is borderline ovarian cancer? Now it is a malignancy which has a low malignant potential. It remains confined to ovary for long duration as opposed to invasive which starts spreading. It is more commonly seen in premenopausal women and younger women. Age group is 30 to 50 years, whereas invasive cancer is more common in postmenopausal women and age is after 50. 50 to 70 years is the peak of the age group for the invasive ovarian cancers, especially epithelial cancers. Now, this borderline ovarian cancer has got overall good prognosis because it remains confined to ovary for a long duration. Rarely there are case reports which are showing that this serous borderline tumors sometimes has got abdominal implants, extra ovarian, leading to intestinal obstruction and death, but that is rare. Overall, these borderline ovarian cancers have got a good prognosis. What are the epithelial ovarian cancers and what is with which cells these epithelial cancers resemble and which is the commonest and which is the least common? If you are asked this question, which is the commonest epithelial ovarian cancer? What are the various types of ovarian cancer? Your answer should be serous is the commonest. It is seen in 80%, it occupies 80% of all the epithelial ovarian tumors, serous tumors, which can be either benign, borderline, or malignant. Cell resemblances with endosalpingeal cells or cells of fallopian tube. Now, for serous tumors, we have to remember that it is further divided in the last few decades. We have understood that there are two types of this serous cancer, serous invasive cancer. One is type 1 and type 2. Whenever it is borderline or low grade, it is type 1, and type 2 is high grade. Now, P53 mutation is not seen with type 1, but P53 mutation is seen with type 2, and it is overall a very aggressive tumor which spreads very fast and it is associated with relatively a poor prognosis. What is important to remember that we have understood in the last few years is this type 2 is, though it is ovarian mass, the cell of origin is femoral end of the fallopian tube. So this type 2 is originating from the femoral end of fallopian tube. Whereas this endometrioid and clear cell tumors, the origin is from endometriosis. Other tumors, now number 2 is not mucinous, it is endometrioid, which occupies 10% of all the epithelial tumors, and it resembles proliferative endometrium. Clear cell and mucinous each responsible for 5% of epithelial tumors. Clear cell tumor resembles Mullerian epithelium. Mucinous tumors resemble epithelium of the GI tract or endocervical cells. Undifferentiated and Brenner together are responsible for less than 1% of the epithelial ovarian tumors, and Brenner tumor, the cells are resembling those of bladder, transitional cells are present. Now, what is the staging of ovarian cancer? How do you stage ovarian cancer? You should say that it is surgical staging so that we operate on a case, and depending on the surgical post-surgical histopathology, we divide it in the 4 stages. Stage 1 is when the disease is limited to ovary. Stage 2 is there is a spread, but it is limited to pelvis. Stage 3 is spread above the pelvic brim, that is abdominal cavity, and stage 4 is distant metastasis. So one by one we will see all these stages. Stage 1A is when it is limited to ovary and only one ovary is affected, whereas stage 1B is when the presence of the tumor is in both the ovaries but there are no other extra ovarian metastasis. For 1C, it is interesting to remember that it has 1C1, 1C2, 1C3. 1C1 is when we are operating and accidentally there is a rupture of the capsule. So surgical spiel is C1. Whereas if it is a spontaneously ruptured capsule preoperatively, it is not because of our operative surgical interference, then that is C2. So in comparatively, the risk is greater when it is a spontaneously ruptured capsule as compared to surgical spill. Surgical spill is C1, whereas spontaneous capsule rupture is C2. C3 is when ascitic fluid or peritoneal washings are positive for malignant cell. Now remember that still, if there are no extra ovarian metastasis, it is still stage 1. So many times we have a wrong concept that anytime ascitic fluid tapping comes positive for malignant cells, it is a late stage disease. We consider it to be either stage 3 or beyond. It is not like that. It is a wrong concept. We need to remember that if there is no evidence of extra ovarian metastasis, the uterus, there is no spread to the fallopian tube. Even peritoneum, microscopic spread to peritoneum or lymph nodes is also not there. There is nowhere else there are metastasis. Then it is still stage 1. Though it is stage 1 C3, that means the prognosis is good. In spite of ascitic fluid showing presence of malignant cells is important concept I want all of you to remember. Stage 2 is spread to the pelvis. A is when the spread is to tube, uterus or opposite ovary. And 2B is other pelvic tissues such as pelvic peritoneal involvement will come to stage 2B. Now, now when we come to the stage 3 and stage 4, and stage 3 is somewhat complicated. Stage 1 and stage 3 as compared to stage 2 and stage 4, which are relatively easier. But to remember, it is abdominal spread, and stage 3 is further divided into stage 3A, stage 3B, and stage 3C. To remember it is, we can remember in this way that stage 3A1 is lymph node involvement and stage 3A2 is microscopic peritoneal involvement. That is how you can remember that whenever it is lymph node involvement, it is always stage 3A. And if it is, we are taking peritoneal biopsies to know whether microscopic peritoneal involvement is there whenever gross disease is not seen at the time of staging laparotomy. And if the microscopic peritoneal involvement is present, then it will be stage 3A2. In the A1, again, it is divided as small 1 and small 2, depending on the size of the lymph node metastasis, less than 10 millimeter and greater than 10 millimeter. 3B, from 3B onwards, there is macroscopic peritoneal involvement of the abdominal peritoneum, and size less than or equal to 2 centimeters is B, greater than 2 centimeters is C. Liver surface nodules are also included under 3C when there is no parenchymal liver involvement. Stage 4A is positive pleural effusion, where the pleural tapping shows malignant cells. 4B is distant metastasis or parenchymal metastasis such as liver metastasis. So this is, you draw it. Why I am drawing all these line diagrams is for you only, for students only, so that if you practice drawing it like this, it helps you to understand and remember, and it is also easier whenever in theory paper you draw such line diagrams, then for examiner also it becomes clear that your concepts are correct. What are the indications of genetic testing in ovarian cancer? More and more, whenever we go for recent advances in all the malignancies, there is emerge such as endometrial cancer, ovarian cancer. There is more and more emergence of genetic testing, and the reason is it is also helping us in catching the carriers in the family members and prophylactically treating them and preventing the cancer in those younger women, as well as it helps us in management. So whether we should do genetic testing in all the ovarian cancers, yes, your answer should be it should be offered to all women with epithelial ovarian cancer. A detailed family history should be taken related to breast, ovarian cancer, colon cancer, especially malignancies associated with Lynch syndrome. We have to take the endometrial cancer, we have to take the history. In 40% of BRCA1 gene mutation positive women, there is no family history. That means it is a separate event which has occurred. This gene mutation has taken place in that woman only without any uh, presence of the same gene mutation in the family member. That we have to remember that there is a limitation for the of this family history. In spite of negative family history, we need to do the genetic testing. That is the concept. BRCA1, BRCA2 gene mutations are found in 25% of epithelial ovarian cancers. Ovarian cancers occur at earlier age in these women. It is the age is younger by 10 years. Prophylactic salpingo-oophorectomy is indicated whenever there is a BRCA gene mutation positive carrier, especially in BRCA1. The risk of development of malignancy is greater as compared to GRCA2 gene mutations. Now, what is high risk group for ovarian cancer is another commonly asked question. There are certain situations where the risk is more, and there are certain factors which uh, protect a woman against development of ovarian cancer. In the high risk group, nulliparity, low parity is the this is the risk factor at the top for this ovarian cancer, and the reason is it is this terminology that the students should remember. Whenever you are asked about high risk group for ovarian cancer, you must mention incessant ovulation theory. So what is this incessant ovulation theory is, here what is happening is whenever there is a uh, ovulation which takes place, there is a trauma to the surface of the ovary. Ovarian surface is getting disturbed whenever ovulation takes place. Over means release out. There is always a trauma to the ovarian surface, and more the number of ovulatory cycles, more will be the trauma. Though the repair takes place, there is a repeated trauma which is taking place throughout the reproductive life over the ovarian surface. And more are the ovulatory cycles, in short, more will be the risk of this ovarian cancer. That is what is meant by this incessant ovulation theory. So all these factors, nulliparity, low parity, infertility, or infertility, we do give ovulation induction drugs and we increase the trauma. Again, it goes in favor of incessant ovulation theory. Early menarche, late menopause, all these are associated with greater number of ovulatory cycles, and that is how there is a high risk. Whereas pregnancy, lactation, these are protecting. OC pill use, these are protecting a woman against this ovarian cancer by reducing the number of ovulations. Positive family history or genetic mutations, BRCA1, BRCA2 gene mutation positive women, these are also at greater risk for the this development of ovarian cancer. And Lynch syndrome is hereditary non-polyposis colorectal cancer, where there is a high risk of developing not only colon cancer, but there is a long list: endometrial cancer, ovarian cancer, and these women having this Lynch syndrome are also at a higher belong to the high risk group for ovarian cancer. And endometriosis is their long-standing endometriosis. It is a risk factor as it can convert into either endometrioid or clear cell cancer. Now, can we prevent ovarian cancer? And if so, how we can prevent it? Your answer should be yes, to some extent we can prevent development of ovarian cancer. Parity protects. Lactation protects a woman. Even a woman having single child also, there is a significant reduction in the risk of ovarian cancer, as during pregnancy and during lactation, ovulation is suspended. OCPL use is the only proven chemo protection against ovarian cancer. It has been proved that it reduces the risk, and there is a significant reduction with a 5-year use. Longer is the use, more is the reduction. 5-year use there is a 50% reduction in development of epithelial cancers. So OCPL use is strongly recommended whenever there is a positive family history of ovarian cancer. Prophylactic salpingo-oophorectomy, especially in BRCA gene mutation positive women or women where there is a positive family history of either breast or ovarian or cancers under the umbrella of Lynch syndrome, it will prevent development of ovarian cancer. Whenever there is a low risk group, there is no such history of BRCA positivity, or family history is not there of all these epithelial malignancies, and a woman belongs to low risk category, and we are doing hysterectomy for any benign indication, then whether we should do prophylactic oophorectomy, we have to weigh the advantages and disadvantages. These disadvantages of prophylactic oophorectomy will be the ovaries are protecting against ischemic heart disease and osteoporosis. That protection is lost. Postmenopausally, ovary is not a redundant organ. We have to remember that it has a great role in providing CVS and bone protection in the postmenopausal period. And that is the reason we have to weigh, we have to properly counsel, and then only take a decision about prophylactic oophorectomy in low risk group. Prophylactic salpingectomy, on the other hand, is now being recommended more and more by various guidelines whenever we are doing hysterectomy for the benign disease, and it is indicated in low risk women, prophylactic salpingectomy. Now, role of this tubal ligation and hysterectomy for the prevention of ovarian malignancy, there is a question mark. And the rationale which is given about it is how the tubal ligation or hysterectomy prevents development of ovarian cancer is by reducing endometriosis. What is the place of screening for ovarian cancer? If you are asked this question, whether there is a way we can screen the low risk women or high risk population for the development of ovarian cancer, your answer should be screening is, as far as screening for ovarian cancer goes, it is a failure. The reason is when we do CA-125 or we do transvaginal sonography, it is associated with high false positives in premenopausal women, especially. CA-125 is not at all specific for ovarian cancer in premenopausal women. The level is seen, raised values are found even in 1% of normal females, as well as whenever there is any disease which is irritating the peritoneal surface. We can remember all the reasons like that. That if there is a fibroid, if there is a this abdominal tuberculosis, or even if there is a pelvic inflammatory disease, endometriosis, in all these conditions, CA-125 rises. So the raised value is not at all specific for ovarian cancer. Similarly, with transvaginal sonography, we can get ovarian enlargement, which is not because of ovarian cancer, very commonly in premenopausal women, as we have already seen the differential diagnosis in the first slide itself. So high false positives are there with both of these, and even if we do, and it leads to unnecessary, there is a risk of unnecessary surgeries. And even if we do it on annual basis or 6 monthly basis, even in the high risk group, still early detection of the cancer is not achieved, and so that it does not get converted into reduction in mortality or 5-year survival rate improvement. And that is the reason these cannot be used for screening, and screening is not possible even in high risk women. In high risk women, that is why what is recommended is prophylactic salpingo-oophorectomy to prevent the occurrence. But we cannot screen low risk or high risk population to select out the women who are at greater risk. That is not possible with the ovarian cancers, unfortunately. If we compare the screening of cervical cancer and ovarian cancer, the cervical cancer, it is a big success story. With the proper screening, there is a reduction in cervical cancer drastically, but that is not applicable for ovarian cancer. Ovaries are deep rooted in the peritoneum, not accessible for the cytology, and the early stage disease is not producing changes such as early stage disease, unfortunately, doesn't lead to rise in CA-125. That we have to remember as a concept. Early stage disease will not be giving the peculiarities of the malignancy on sonography also. And that is the reason, and there are so many conditions which mimic the changes in the ovaries, even if the disease is benign. And that is the reason this ovarian cancer screening is a big challenge at present. Now, this is another favorite question which is asked to the students, and clinically also it is most important that any patient who comes to us and there is a ovarian mass on examination, adnexal mass is there and ultrasonography shows presence of ovarian tumor, can we suspect whether it is a benign tumor or a malignant tumor? Can we differentiate preoperatively? So for that, the most common method which is used is this risk of malignancy index 1. It has been recommended by NICE guideline, UK guideline 2023 is also recommending this only, that you use preoperatively whenever there is a suspected ovarian cancer. The first step which is to be taken by clinicians is to do RMI1 calculation. And if RMI1 is greater than or equal to 250, it is an indication to refer the woman to specialty center where gynec oncology facilities are available. That is another recommendation by NICE 2023. Now, this risk of malignancy index 1 score was introduced by Jacob in way back in 1990, and then it was followed by introduction of RMI 2, 3, and even 4. But all these, when they were compared, it has been seen that RMI 1 has greatest sensitivity and specificity, and that is why it is being recommended. What is RMI 1? Is a multiplication or product of these three. CA 125 value in units per milliliter multiplied by ultrasonography score multiplied by M, that is menopausal status. For UHG score, there are 5 parameters. As we can see here, you have to remember these 5 parameters which are included in under this RMI1. One is presence of solid areas in the ovarian mass. Second is multilocularity. Third is if it is bilateral tumor. Fourth is presence of extra ovarian metastasis, and fifth is presence of ascites. A value of 1 is given to each parameter. Now, if it is a 0 score, then overall U score is 0, and because it is multiplication, RMI1 will be 0. So that if a woman comes to us with the report that there is a ovarian cyst without any solid areas, unilocular, limited to one ovary, no extra ovarian metastasis, and no ascites, then naturally RMI1 for that woman will be 0. If it one parameter is only there, that is if you get a ovarian cyst which is multiloculated, then one score of 1 is given for this U. And if any time it is 2 or more parameters are present, that there is a presence of solid area as well as ascites, then the score of 3 is given. That is how the scoring is done for this U or ultrasonography score. For menopausal status, premenopausal, a score of 1 is given, and postmenopausally, a score of 3 is given, because we know that postmenopausally, the risk of malignancy drastically increases as compared to premenopausal women. So this is RMI1, which all of you should be able to reproduce, memorize, and use in clinical practice also, which is a pre-surgical uh, tool which helps us to differentiate between benign and malignant. It helps us to do the proper counseling of a woman as well as to prepare us mentally and plan the surgery also in this woman. Whenever we want to plan the options of surgery, discuss the options of surgery, it helps us in a great manner. So if you are asked the question, can you differentiate between benign and malignant ovarian tumors by ultrasonography? Your answer should be yes. And for that, what we use are the IOTA simple rules which were introduced in 2008. IOTA is International Ovarian Tumor Analysis Group. It was by radiologists, and they introduced these simple rules by which we can differentiate between a benign and malignant ovarian mass. And we have to interpret the result accordingly. These are 5 B rules are there and 5 M rules are there. So for B rules, we have this 5 where there can be a unilocular cyst which can be present there, unilocular cyst. Or there can be a smooth multiloculated cyst, but the size is, though it is multilocular, if it is less than 10 centimeters and smooth surface, then also it is suggestive of a benign. If in a tumor there is a solid component, but it is less than 7 millimeters, then also it is suggestive of a benign tumor. Now, what is the presence of acoustic shadow is whenever ultrasonography is being done, and in that case, if there is a shadow is seen, acoustic shadow or black area is seen, it is because of the sudden change in the impedance, and that is suggestive of a this benign tumor in ovarian masses. And if there are no Doppler signals, that is also suggestive of the benign tumor. So these are the five. First is a presence of this unilocular cyst. Second is multilocularity but smooth surface, size less than 10 centimeters, solid component less than 7 millimeters, presence of acoustic shadow at no Doppler signal. Now coming to the M rules, there are five rules in this suggestive of malignant also. First is a presence of a irregular coming to this M rules, we have this irregular, suppose there is a irregular solid tumor, surface is irregular, that is M rule. If it is a multiloculated with the solid areas in between, and if the size is very great, greater than 10 centimeters, and though it is multiloculated, some solid areas are their size greater than 10 centimeters, it is suggestive of malignancy. Now, whenever we do ultrasonography, sometimes we are able to appreciate these papillary structures arising from the tumor wall, and if these are greater than 4 in number, that is suggestive of malignancy. Presence of ascitic fluid, that is suggestive of malignancy. And if on Doppler there is a high vascularity, high Doppler score of greater than 4, that also goes in favor of malignancy. Now, how we interpret is interpretation. That is important. Interpretation is, when do you say it is benign? When at least one B rule is there and no M rule. Malignancy, at least one M rule and no B rule. And inconclusive will be either neither B or M features or combination of B or M. For example, one patient has got a ovarian tumor with a solid component less than 10 millimeters, but there is presence of ascites. That means there is one B rule, one M rule, then it is inconclusive. What has been seen by studies is as high as 85% of the cases of ovarian masses, we can differentiate between benign and malignant with the help of this iota, whereas in rest of the cases, it will be inconclusive. As gynecologists, we should be aware about RMI1 as well as iota. The reason is, preoperatively, if we use both, we are pretty confident whether we are dealing with a benign or a malignant tumor, and accordingly we are counseled. We can plan the our surgical uh, steps also, or we can plan the patient, especially fertility conserving surgery. For these cases also, it helps us a lot. Now this is new Roma. Roma is risk of malignancy algorithm which has been introduced, and it is at present under research. It is not used in clinical practice. Where what is being used, it comes under recent advances related to the preoperative selection assessment of the women with ovarian tumors, where what is assessed is CA125 and human epididymis protein 4, HE4. These two are done, and these are repeated frequently. And what is to be seen is whether there is a rising trend of CA125 rather than the absolute value. As we know that absolute value, it will be in units per ml, and anytime it is greater than 35 units per ml CA125, it is a raised value. But here we are not dependent on the absolute value. The reason is low grade tumors, borderline tumors, they are not secreting that much of leading to rise in CA125 to that extent. And that is why it is thought that with the early stage disease and with the borderline tumors, the Roma will be of greater help as compared to RMI1. Now, presently, it is not still recommended because there is no sufficient scientific evidence, and RMI1 is having a better specificity. But we have to remember that it is also one of the emerging way of trying to differentiate between the benign and malignant ovarian tumors preoperatively. So there are three ways. One is RMI1, second is iota, and third is this Roma. What are the tumor markers for ovarian cancer? By this time, I think students, for all the students, the tumor markers must be at the tip of the tongue. What you need to understand is tumor markers cannot be used for screening of ovarian cancer. They help us in diagnosis and treatment. Now it is such an extensive topic, ovarian cancer, that I have included only the important concepts and most commonly asked questions related to ovarian cancer. CA125, it is a glycoprotein associated with Mullerian tissue. It is rise is not specific for ovarian cancer in reproductive age. It is more specific postmenopausally with a value greater than 35 units per ml. Greater than 200 units per ml suggests epithelial ovarian cancer of non-mucinous type. Whereas with mucinous cancers, the tumor markers are carcinoembryonic antigen and CA19-9. Alpha fetoprotein is a tumor marker for endodermal cyanide tumor, SCG for ovarian choriocarcinoma. LDH is for dysgerminoma. LDH helps in even a treatment also for dysgerminoma and detection of recurrences also. AFP, SCG both are secreted by embryonal carcinoma. So young girls, solid ovarian mass, we need to do all this, especially to know whether it is a germ cell malignancy or mixed germ cell tumors are also common. All these tumor markers help us in treatment in the way that we can decide how many number of chemotherapy cycles to be given. They do tell us about response to treatment as well as recurrences are detected with the help of all these tumor markers. Granular cell tumor, remember inhibin is the tumor marker. It is also helping for diagnosis as well as treatment. What is the place of laparoscopy in ovarian masses? Laparoscopy can be used whenever mass is likely to be non-malignant. So we use all these RMI or USG criteria, and then we decide whether to proceed if the possibility is of benign tumor. Cystectomy can be done in carefully selected cases. It can also be used with ovarian torsion. Frozen section is to be done intraoperatively whenever we use this cystectomy. And if the report comes as malignant, we have to proceed with all the steps of staging laparotomy. We need to be careful not to have any spillage, and endobag use is recommended, or small mini laparotomy can be done for removal of the mass without spillage. What is important precaution is excessive use of cautery is to be avoided on ovarian tissue after doing a cystectomy to maintain ovarian reserve. This is another commonly asked question. What are the steps of staging laparotomy for ovarian tumors? So whenever we are suspecting malignancy, vertical incision to be given. If present, ascitic fluid is removed. If ascitic fluid is not there, multiple peritoneal washings are taken and sent for cytology. Careful inspection, palpation of complete pelvis and abdomen is to be done in a clockwise manner. Total abdominal hysterectomy with bilateral salpingo-oophorectomy is done. Peritoneal biopsies are taken from 8 sides: anterior posterior fornix, both sides pelvic side walls, both sided paracollicators, and right and left hemi-diaphragm. For microscopic peritoneal metastasis, whenever gross disease is not seen in over the pelvic or abdominal peritoneum. Lymph node assessment and sampling of the pelvic lymph node and para-aortic lymph nodes is done. Now this is an important terminology. Lymphadenectomy, block lymphadenectomy is not done, as it leads to more of a development of lymphedema and postoperative morbidity. So what is done is lymph node assessment and sampling. Appendicectomy is recommended whenever there is a mucinous cancer. And aim of staging laparotomy, apart from this staging, the other aim is important is optimum cytoreduction. What is the place of fertility sparing surgery in ovarian tumors? Now remember, for students, fertility sparing surgery, you can get a question on fertility sparing surgery in gynecology as such in your recent advances, so that you have to include fertility sparing surgery in ovarian cancer, ovarian tumors, fertility sparing surgery in prolapse, in fibroid uterus, and so on. Prerequisites for that are, whenever it is a young woman who is desirous for pregnancy, willing to come for follow-up, there are no dysgenetic gonads, and proper at the end of proper preoperative counseling and proper consent only we can take a decision to proceed with this fertility sparing surgery. Indications are whenever unilateral tumors are there, germ cell tumor, sex cord stroma tumor, or borderline tumor, or early stage, that is stage 1 invasive epithelial cancer, we can in these women we can do the fertility sparing surgery. What is done in fertility sparing surgery is whenever there is a suspected malignancy, we are doing unilateral salpingo-oophorectomy. So that sided tube and ovary we are removing. We are not removing uterus and opposite sided tube or ovary. We are even not taking biopsy from the opposite ovary because it will lead to peri-ovarian adhesions and it will reduce the fertility potential. Frozen section is to be sent, but remember that for grading of tumor, frozen section is not always reliable. If it is malignancy, we have to proceed with the remaining staging as we do staging laparotomy. Peritoneal biopsies, lymph node assessment, omental biopsy, diaphragm assessment is done same as for the uh, women. Otherwise, without fertility sparing, whatever steps are taken in staging laparotomy, remember that these are to be included whenever we are doing fertility sparing surgery. Only difference is we are not doing hysterectomy, we are not removing opposite sided tube and ovary. What is the differential diagnosis of solid ovarian tumors? Brainer tumor, teratoma, dysgerminoma, fibroma, fibrothecoma, thecoma, granulosa cell tumor, and Brukenberg tumor. What is the goal of primary surgery? Goal is surgical staging, optimal cytoreduction. How do you define optimal cytoreduction? No visible or palpable residual disease to be remained, or if it is not feasible, at least less than 1 centimeter residual disease. That is the definition of optimal cytoreduction. Why torsion is common in mature teratoma? It has more of a fat content. That is why weight is less. It is floating freely in peritoneal cavity. Sometimes it is palpable in anterior fornix also. It stretches the ovarian ligament, and that is why it is more prone for torsion. In the torsion, what is included is this infundibulopelvic ligament, ovarian ligament, sometimes fallopian tube also, and the tumor itself. These are the structures involved in the twist or torsion. How will you manage torsion in ovarian tumor in a young adolescent girl? If it is asymptomatic, indications of surgery are specific. If it is solid tumor, we have to operate. If it is a cystic but size greater than 8 centimeters, we can operate. Or if it is when it is kept under follow-up and increasing size is seen, then we should operate. So selection of surgery is to be done carefully in adolescent girls, as post-operative adhesion formations, ovarian or tubal adhesions will reduce the fertility potential. Again, important concept, risk of malignant ovarian germ cell tumors is more in pre-pubertal girls than in adolescent. If there is a torsion, then laparoscopy can be done, untwisting of the adnexal size done. And even it is successful even in presence of necrosis also. Detorsion is followed by cystectomy. Ovarian function is preserved in majority because the ovarian blood supply is through infundibulopelvic ligament, and after detorsion the blood supply is getting re-established in majority. Adnexectomy is rarely required in neglected torsion where there is a superimposed gross necrosis and infection. Which ovarian tumors can lead to endometrial hyperplasia carcinoma? These are the hormone producing tumors, which are sex cord stromal tumors, granulosa and theca cell tumors, where patient presents as heavy menstrual bleeding, AUB in reproductive age, and postmenopausal bleeding also can be the presenting symptom. Early detection is common because of this presentation, and overall prognosis is better. What is primary, adjuvant, and neoadjuvant chemotherapy? Primary is first line chemotherapy used as first line treatment. Adjuvant is whenever it is being given after the surgery. Neoadjuvant is where there is a sandwich technique. You give few cycles of chemotherapy, operate, and then give the remaining cycles. Indication is for advanced cancer with less likely optimum cytoreduction. Prerequisite is we need to have a pathological diagnosis of ovarian cancer, and it can be done by ascitic fluid cytology, USG guided biopsy, and if it is also not feasible, laparoscopically directed biopsy can be done. How genetic testing helps us in treatment? BRCA positive germline, that means patient's sample, or from the tumor, somatic from tumor. These tumors have greater sensitivity to platinum chemotherapy. So platinum based chemotherapy is preferred. They also respond better to this poly-ADP ribose polymerase inhibitors. These are called as PARP inhibitors. They are given as maintenance therapy after completion of platinum chemotherapy. And FDA approved PARP, you can remember these two names. These are niraparib and olaparib. Remember, there is a parib at the end, and you can add nira and ola. So niraparib, olaparib. Which chemotherapy is given for various types of ovarian tumors? I have done it in a very short manner. It is otherwise you must be reading it in detail from textbooks. No chemotherapy for stage 1A grade 1 cancer and for borderline tumors, not necessary. Chemotherapy is given three on the basis of 3 weekly. Now there were studies carried out where weekly administration was tried, but still the results are better with 3 weekly chemotherapy. For low stage epithelial cancers, carboplatin with paclitaxel is preferred. If it is advanced stage disease, intravenous or intraperitoneal chemotherapy can be given. But remember, intraperitoneal is still under trial. It has not come in the routine clinical practice. Platinum and taxane group, along with that, bevacizumab is given in advanced stage disease. It is a monoclonal antibody which improves the survival rate or disease-free interval. BARC positives, we have already seen platinum-based chemotherapy followed by PARP inhibitors. For malignant germ cell tumors, bleomycin, etoposide, cisplatin. This is BEP regime which is preferred. What are the Krukenberg tumors? These are the secondary metastatic tumors. Primary can be in the colon, stomach, breast, appendix, biliary tract, and rarely bladder or cervix. How it changes the management, we need to search for the primary and treat the primary, but in some few cases it is difficult to detect the primary with a Krukenberg tumor. These are usually bilateral solid tumors with under microscope what is seen is mucin filled signet ring cells. Thank you so much. It has really been a very extensive and a lengthy topic, and I hope I have enjoyed preparing it. I hope that you also will find it beneficial. I have taken help from Novak's Gynecology, Tilland's Gynecology, the latest editions, and I have also gone through NICE Guideline 2023. Thank you once again.